First of all, good evening to everyone that's joined and welcome to our IVF seminar. We're so glad that you've chosen to spend your evening with us. Tonight, we're very honored to have Dr. Jennifer Agard here to guide us through the IVF process at Pacific Fertility Center. This is a really great opportunity to gain valuable insight and better understand what to expect on your individual fertility journey. Throughout the presentation, please feel free to submit your questions at any time using the chat option, or you can do the question and answer feature. That should be at the foot of your screen. At the end of the presentation, we'll be able to address all the questions that come through. So feel free to send those over at any time when they come to mind. And as a special thank you for joining us tonight, we're offering a $99 new patient assessment for those without insurance coverage. This includes an initial consultation and a follow-up ultrasound, and it's a really great first step towards understanding your fertility, your individual fertility options. So with that said, let's get started, and please join me in welcoming Dr. Jennifer Agard.
Thank you so much, Stephen, for the warm welcome. Hi, everyone, and good evening. Welcome to PFC. I'm one of the 4 physicians here. We're all board certified reproductive endocrinologists. There's Dr. Lee, Dr. Ryan, Dr. Strug, and myself. I am a double board certified in REI and OBGYN. I went to med school at UCLA and did my residency on the East Coast as well as my fellowship with Howard Jones, who was a grandfather of this field and had the first IVF baby in the United States, created the first fellowship, and created the American Society for Reproductive Medicine, our governing body. So it's been a true journey, amazing journey. Okay, but we're not here to talk about me. We're here to talk about you and potentially your options. So tonight we're going to talk about what a fertility evaluation is, what the different fertility treatments are, just kind of overviews, what their success rates, details about our practice, and then we'll have a few minutes for questions afterwards. Okay, introduction to fertility. So when a couple is trying to get pregnant for a younger after a year, then we start doing fertility evaluations. If she's 35 or older, then it's after 6 months that we start a fertility evaluation. More and more, we're getting people who just want a fertility evaluation before they start trying to get pregnant. It is also indicated that if the woman is 40, to just have an immediate fertility evaluation, just to know what's going on before spending time trying to get pregnant, because we want to make sure everything's as normal as possible. So some of the things that we do for fertility evaluation is check to see if you're ovulating with home ovulation predictor kits. We can check for ovarian reserve. We do that with AMH and FSH. We can check to see if her tubes are open. That's called a HSG or hysterosalpingogram. And also assess the uterus with an ultrasound. That'll show us the lining, make sure it's a normal lining thickness, see if there's fibroids, adenomyosis, a lot of things that we can see with an ultrasound. Also, when we are evaluating for the reasons why couples can have a difficult time to get pregnant, we ask questions about endometriosis, such as pelvic pain, pelvic, pain with periods, laparoscopies to assess for pelvic pain and diagnosis of endometriosis. About 40% of couples who have a difficult time getting pregnant, we discover that there is a male factor, so that would be done with a semen analysis. However, about 20 to 30% of the cases of couples who need help to get pregnant, we don't find anything wrong, and that's called unexplained infertility. Okay, so this is the fertility curve. This is showing the pregnancy rates in conjunction with a woman's age. This curve, you can see, dates back to the 1600s and lots of different ethnicities here. I like this curve just a little bit better. Gives a little more details because it also includes miscarriage rates. So pregnancy rates is the top curve here. It's based on a woman's age. As a woman is in her 20s, pregnancy rates is the highest, and that's 20% per month. When we get into our 30s, it starts to decline. Then at the age of 35, it's 10% per month. At the age of 40, it's 5% per month. And at the age of 45, it's 1% per month. Then at the same time, the rate of miscarriages drastically increases. For a long time, we didn't understand why this curve was this way. As I mentioned, it's around over 400 years old. It's been cross-culturally verified and it's still accurate. So we didn't understand this curve until IVF came along. And what that did for us was it gave us access to embryos and thus more information. So when we do IVF, we fertilize the eggs in the lab. We grow them for a week until they're an embryo called a blastocyst. This is a ball of hundreds of cells. The inner cell mass makes the baby. The outer cell mass or trophectoderm makes part of the placenta. What we do in IVF now is we take a couple cells away from the trophectoderm, the preplacental cells, and we send them off for a karyotype. A karyotype is the count of chromosomes. Each chromosome has thousands of genes, so it's all the genetic information for the embryo. The embryo gets one chromosome from the sperm and one from the egg for each type. There's 23 pairs in total, and the last set makes the X's and Y's, which determine male and female. If the embryo gets anything other than 2 chromosomes for each type, then it's too much of a genetic imbalance, and that embryo will either not implant or implant and miscarry. There are some exceptions, such as Down syndrome. This is where 3 chromosomes exist for number 21 that can make a live birth, but for the bulk of these, they generally cannot. So in a study of 5,000 couples who went through IVF and had their embryos tested for a karyotype, what we found was that the percent of embryos with a normal karyotype, which is what we call euploid, was linked with maternal age. So you can see the curve of the orange bars reflects the pregnancy rate of that natural fertility curve. And the aneuploid embryos or embryos with an abnormal karyotype are the green bars. And the curve of the green bars follows the miscarriage rate of that natural fertility curve. So now we understand why it can be more difficult to get pregnant as we get older and we go through more miscarriages. If you're a mathematical person, this is another way of seeing that graph. So pregnancy rates decline as women get older, exactly what I just said. The miscarriage rates increase as women go older, and chromosomal abnormalities that occur in a live birth increases as women get older. In fact, that Down syndrome is 1 in 40 at the age of 40. So there's age and there's ovarian reserve, and then there's kind of like the continuum of a woman's fertility lifespan. So in our 20s, like I mentioned, that's our optimal fertility. That's a time when a lot of women don't want to get pregnant because we're, working on different aspects of our life, maybe career building. And then as we get in our 30s, our fertility starts to decline. This is a phase where diminished ovarian reserve can be seen very frequently. And then after diminished ovarian reserve, there's perimenopause for about 5 years, 5 to 10 years. And then after that, there's the diagnosis of menopause. And that's just the definition of no period for a year. Perimenopause generally is characterized by irregular cycles. So how do we evaluate ovarian reserve outside of age? Because we know there's women who are fertile in their 40s and there's women who go through menopause in their 20s and 30s. So age isn't everything, and we still need to assess what's going on. Well, the best ways to assess ovarian reserve is with an AMH and antral follicle count. Those two are also the best ways to predict how many eggs you would get in an IVF cycle. Okay, for quality, it's a woman's age and her FSH levels. Those are the best predictors of how the eggs are going to function. To kind of understand ovarian reserve, I like to take a step back and go over how the ovary works. So here's your little ovarian physiology class. Women are born with all the eggs that they're ever going to have. They're born with about 1 million eggs in the ovaries, and they can't be seen or quantified in any way. They don't make hormones and they don't respond to hormones. So they're just kind of hibernating there until a girl goes through puberty. Then the ovaries become active and they select a group of the dormant follicles and convert them into the active follicles. These are fluid-filled sacs that we can see on ultrasound, so we can count these. They're also hormonally active. They make the estrogen in your body and a hormone called AMH, or anti-Mullerian hormone. They also have receptors for FSH, so they respond to hormones. Usually based on your age, there's somewhere between 10 to 20 active follicles per ovary. In a natural cycle, our brains make enough FSH to get one of these follicles to grow, become a mature egg, and then ovulate or release that egg. At the end of the cycle, all those active follicles that weren't selected to be ovulated, the ovaries discard, and the eggs are single cells, so they easily disintegrate. When you get your period, the ovaries select a new group of dormant follicles, convert them into active follicles, and then the process repeats itself. So this way, your ovaries are discarded discarding somewhere between 20 to 40 eggs every single month. When we do IVF, we are just giving you higher doses of FSH to get the majority, if not all, of your active follicles to respond, become mature follicles that we can get in an egg retrieval. Okay, so that's your ovarian physiology class. Diminished ovarian reserve is when there's a lower than typical count of follicles. So we tend to have this happen as we get older, part of the natural aging process. But again, it's not always determined at a certain age for everybody. There's a lot of variability. Okay, so when we do an ultrasound to look at the ovaries, this is what an ovary looks like right here. And you can see these little black circles. Those are the active follicles in the ovary. This right here is not a follicle, that's a blood vessel. But you can see easily like 10 to 12 active follicles here in the ovary. In contrast, here's an ovary that just has a few, maybe 1, 2, 3 active follicles. So this ovary would represent diminished ovarian reserve. This would be normal ovarian reserve. Okay, so again, ovarian reserve is an assessment of reproductive potential by quantifying the egg number and the egg quality. It gives us insight. All right, so that's how we evaluate the ovaries. We spend a little bit more time on that compared to semen analysis because it's just more complex of a concept. When we're trying to help you get pregnant, there's different ways that we can help you. So there's ovulation induction and intrauterine insemination. There's IVF. There's egg donation, sperm donation, and gestational carriers. So who is a candidate for ovulation induction? So generally, women who have unexplained infertility, women who have polycystic ovarian syndrome, usually women who are younger, like trying to get pregnant in their 20s, or they're just wanting to step into fertility treatment before they take the dive into IVF. Doing ovulation induction with IUI, there's variable reports of the optimal times. Some women just want to try, couples want to try one IUI cycle. Some really want to try, 3 to 4. I think 6 is just a little bit on the high side now. But yeah, because after about 3 to 4 IUI cycles, we notice that pregnancy rates start to decline. And it's not that doing the IUI cycle causes any harm, it's just that the people who it works for are off being pregnant, and the people who it doesn't work for are hanging out. And that's the, you know, that's the statistical model. Okay, when we do ovulation induction, we're giving you medications like Clomid or letrozole to induce ovulation or augment ovulation. And then at the time of ovulation, we're washing the sperm and putting the sperm inside the uterus. So it gets more sperm in closer to the egg. This boosts pregnancy rates, and dependent on your diagnosis and your age, somewhere between up to 10 to 12%. Okay. There have been past, 2014 is quite a while ago. I think that for most papers, it's somewhere, based on age, based on the diagnosis, and these are more reasonable rates that we can quote. Okay, so IVF, who are the people who should be doing IVF? So if you haven't had success with IUI, that's a good indication to doing that. If you are a couple with male factor and low sperm count, and you don't meet the minimum criteria for the number of total count for an IUI, it's more beneficial to do IVF. Ovulation dysfunction, that means a lot of PCOS, women with PCOS do have to go on to IVF. Endometriosis is one of the diagnoses where it's best served with IVF. The success rates with IUI is quite low. Doing PGTM, which is where we're testing for recessive mutations or, oncomutations like BRCA. So you don't want to pass on a genetic trait that we can test for. That's an indication to do IVF. Or just doing fertility preservation. You can freeze embryos for potential children in the future for family building. Other people who need to do IVF is co-maternity couples, so same-sex female couples who want to carry each other's embryos, gay men who want to use a surrogate, an egg donor, to create their family. Okay, so what is the IVF process? So we're going to go through that. First, like I mentioned before, we're getting lots of follicles to grow. It's an average of 10 nights of injections. Then we do the egg retrieval, where we get the eggs from the follicles. We fertilize them, grow them into embryos, do an embryo transfer, and freeze remaining embryos. So this is what the ovaries look like after a woman has taken lots of nights of injections of FSH or follicle stimulating hormone. Again, you can see some small follicles there, but you see multiple large mature follicles. So the size of a follicle correlates with the maturity of the egg. Each follicle has one egg, and you can't see an egg on the ultrasound because it's a single cell. But we do have a correlation between the sizes of the follicles and the maturity of the eggs. When the eggs are ready to come out, we do an egg retrieval. And this is done under anesthesia in our OR in our office. So you will be asleep. There's another ultrasound in the vagina, but alongside the ultrasound is a needle that goes through the vaginal wall and into the ovary. And then we aspirate the egg into the test tube and give those eggs off to the embryologist. Here's a fun video. So you can see here's the needle, and it's going into the follicle, and then it drains all the fluid out of the follicle. And we collect the fluid again in that test tube and give them to the embryologist to fertilize. It's about a 20, 30-minute procedure. Okay. Again, an egg is the largest cell in the body. It's surrounded by supportive granulosa cells. And conventional fertilization, we fertilize the eggs with the sperm by incubating the sperm with the eggs. In There's another form of fertilization called ICSI, intracytoplasmic sperm injection. And that's when we have low counts of sperm that don't meet minimum needs for conventional fertilization. So this is the egg. Here, the sperm is in this little needle, microscopic needle. This is all being done underneath the microscope. And then the needle's going to inject the sperm into the egg. Here's the tiny little sperm right here. I hope you can all see that. There we go. And so the zona pellucida is just a surrounding shell of the egg. So the sperm is being placed inside the egg. That bypasses about 14 steps of fertilization. So there's 11 more steps-ish. Okay, and that's ICSI. All right, so once the egg has been fertilized, then the egg grows into an embryo. So to check on fertilization, about 80–90% of the eggs fertilize in the IVF lab. And 24 hours after the eggs have been either incubated or injected, then we check on fertilization. And this is called a 2PM. This is two polar nuclei, and that's the positive affirmation of fertilization, polar bodies. Now it's divided into 2 cells. Very exciting. So beautiful to watch this every time. And now we're going into 4 cells. That's a beautiful 4-cell embryo. Of course, you're going to always see the most beautiful things. So again, 2PM, that's a single cell that has 2 polar bodies. That tells us it fertilized. It divides on day 2 into 4 cells. Day 3 has about 6 to 8 cells. Day 4, it compacts into a morula. We don't have that picture here, but on day 5, day 6, and day 7, they develop into a blastocyst. Now, not every single fertilized egg grows into an embryo. There's a natural attrition rate. So there's a wide variety of blast rates. That's what we call blast rate, the percent of fertilized eggs that grow into an embryo. All right, here we got some more fun videos. So this is going to show us how an embryo grows into a blastocyst. So this looks like a cleavage stage or day 3 embryo. And then you can see it compacting. Beautiful. That's compaction right there. And then it's expanding, and then you see a fluid-filled area right here, and that's the blastocele. So this embryo is called a blastocyst because it has fluid inside the cavity. And now it's hatching out like a little chick. That's the hatch out of that zona pellucida. And once it's hatched out, it can implant. Okay, so when we have the blastocyst, then we can do testing of the embryo by taking 2 to 3 cells away. So here we're taking a few cells away from the blastocyst. In this video, it takes a few more cells than we do now. That's a bit of a chunk. Now we don't need so many cells, just 2 to 3 cells. That looks like 10. But again, the blastocyst is hundreds of cells, and it does not hurt them. When we first were looking at whether, frozen embryo transfers of biopsied embryos were going to decrease pregnancy rates, we assumed that it would, because we're doing interventions, freezing, biopsying. And then all the studies show that when we're transferring euploid embryos, we found that the pregnancy rates were higher than untested embryos, which was a real surprise to everyone. This is the benefits of PGTA, that's testing the embryos for the karyotype. With our super high rates of single embryo transfers from euploid embryos, we don't feel the need to transfer multiple embryos because our success rates are so high, which has really reduced the twin rate and higher order multiples, which has been fantastic because somewhere around 50% of twins miscarry. So that's reducing the overall live birth rate. Remember, we're always looking at what helps families take home a baby. Testing the embryos removes, transferring aneuploid embryos, which is the number one cause of miscarriage. So that really reduces the miscarriage rates. Of course, we can detect Down syndrome when we test the embryos. Just a reminder, when you get pregnant with PGTA tested embryos, you still have to go through all the standard testing of prenatal diagnosis when you're pregnant, just like everybody else, because it helps increase accuracy and have a healthier outcome. So these are our IVF outcomes. It's based on a woman's age. So for women who are 34 or younger, on average, we get 20 eggs. You can see the different age stratifications. As women get older, the number of eggs that we get declines. From those 20 eggs, we get an average of around 7 embryos. And we do see that blast rate declines as women get older. So even if we were to get 20 eggs from this age group, it'd still only be 2.6 embryos, so a lower blast rate. And then the percent of embryos that have a normal karyotype, that's the euploid rate, for this age group is 58%. And so 58% times 6.9% gives us 4 euploid transferable embryos per IVF cycle. So you can see how that changes as women get older, which is why a lot of families are choosing to do fertility preservation when they're younger and then use those embryos later, as opposed to later doing IVF later, where you're doing multiple cycles to get to a euploid. So it's just more economic. ASRM is our governing body, the American Society for Reproductive Medicine, and they are very highly recommending 1 euploid embryo at all ages across the board. Let's see. Here we go. So you can see in the age of all ages across the board, it's 1 euploid embryo. And 1 euploid embryo. Yeah. So we're following ASRM recommendations. We're very proud of that. Our single embryo transfer rate is around 92%, whereas national average is 34%. So we're definitely leaders in helping families have healthy babies and healthy families, 1 baby at a time. That's the benefits of embryo selection. When we do the embryo transfer, this is what we do. It's kind of just you're awake, there's no anesthesia. It's just a speculum in the vagina, kind of like a pap smear. And we put a catheter through the cervix into the uterus and put the embryo inside the uterus. We have a little video of this here. So you can see the catheter coming down. This is the cervix. Here's the uterus. And then the embryo being deposited right there. And then the catheter being removed. So that's all an embryo transfer is. It's very simple. Very simple procedure. It is, the embryo does have to bond with the endometrium to implant. So it is up to the endometrium and the embryo to form that bond that allows implantation and gives us a positive pregnancy test. Okay, so this is why we are so happy to have 1 baby at a time, right? Twin risks are high. There's, preterm birth happens, higher risk for twins. So the average gestational age that twins are born at is 35 weeks. That means that the babies that are born after 35 weeks are probably typically okay and healthy. They'll have to stay in the NICU for a period of time. Hopefully that course is good and they get to go home. The earlier babies are born, the more problems they're going to have. Their brains aren't going to be as developed, which causes cerebral palsy, the hearts, the lungs, the GI tract. So there's a lot of birth defects that can happen with twins. Other twin risks is again, autism, twin to twin transfusion, intrauterine fetal death, stillborn. So, and then triplets and higher order multiples are so much riskier. Okay, I think I touched about this family. Fertility preservation is definitely something that people are looking at to help, get ready for their future family with either egg freezing or embryo freezing. We know that egg freezing is just as good as the eggs from frozen eggs are just as good as fresh eggs. So they're very successful in making embryos. So yeah, they do that very well. Lots of options for fertility preservation. If you need donor egg, we have the largest frozen egg bank in Northern California. Of course, there's a lot of couples who need them from women who, have gone through menopause or premature ovarian insufficiency. That's women who have high FSH levels, before the age of 40. Decreased ovarian reserve, advanced maternal age, women who've had chemo, radiotherapy, and don't have functioning ovaries anymore. Definitely IVF failure is an indication for donor egg. And of course, gay men needing donor egg and a gestational surrogate. We have lots of different programs, actually. This is just listing 2 programs. There's the 2 blastocyst embryo guarantee. So there's programs where if you buy, certain set of eggs that we guarantee they'll get embryos from that. If you want to test the embryos for PGTA, then you need at least 2 egg lots. So the eggs are frozen in 6 to 7 eggs per lot. There's also the euploid guarantee. So we do have lots of different programs. This is just the tip of the iceberg. Frozen donor eggs is very popular because the time to getting to your embryo is greatly reduced because you're no longer dealing with the egg donor, because the egg donor has already come in, done her cycle, and we have her eggs frozen. As opposed to going with a fresh egg donor, you're going to have to work with her life, her schedule, getting her ready. And there's a lot that, you can't control in that. So it takes more time. It takes more money. It's higher costs. So yeah, the frozen egg bank is very popular. Right. Pregnancy rates and success rates are very high. So clinical pregnancy rate is 53% with transferring 1 donor egg. It can take 2 to 3 embryos, 1 at a time, of course, to get to that live birth, but cumulative pregnancy rates are as high as 78. So very proud of the egg bank. Some fun facts about our practice. We are a great practice with an amazing team of nurses, coordinators, assistants, financial assistants. We have, genetic counselors, fertility therapists. So we're kind of like the whole package. Every person is unique, and we know that. And so we tailor all of our approaches to you. There are financing options if you need that. And we have been here a very long time, and over 10,000 babies have been born from PFC. They've definitely been pioneers in vitrification, which is the cryogenics used now to freeze eggs, and a lot more in a lab, a very highly specialized lab. So we'd love to help you. We'd love to help you have one healthy baby at a time, and help you to have healthy families. Please join us. We have 2 locations now. The San Francisco location is on the Embarcadero. And then we have the Marin location, which is where I am at most of the time, or a good chunk of the time at least. And that's in Green Bay, next to Marin General Hospital. So come and see us. Thank you so much.
Thank you, Dr. Agard. Very informative. We want to open up the opportunity for everyone to ask questions. I do have one question right now that you can get started on, and that is what lifestyle changes improve fertility before starting IVF?
Great question. Thank you so much. So we know that there's some things that affect fertility. So tobacco definitely puts women in menopause 2 years earlier and can cause blocked tubes. So no smoking, vaping, chew, any tobacco products, marijuana as well. You don't want to be using, of course, any hard drugs, but caffeine and alcohol need to be limited as well. So no more than 5 alcoholic drinks per week, because more than that delays time to pregnancy. So we know that there's a negative effect. Caffeine, you should try to only drink like 1 cup of coffee per day type of thing, not 10, right? Exercise is healthy for you, and that's great. You don't need to like have a perfect body or anything like that. Having the BMI over 30 does lower trans implantation rates. So having a BMI of less than 30 is helpful.
Okay, thank you. The next question that came through was, what is the egg retrieval like? Is it painful?
Right. So when you're having your egg retrieval, you're under anesthesia. So you're asleep. So you're not feeling anything. The needle, it's kind of, I've had to do it with some women who can't have anesthesia. And it's kind of like getting a blood draw. Like you feel that needle going in, you feel that pinch, and then it's just there and you can just feel it there. So it's a lot like a blood draw, but it's just a little bit more intense since it's inside your body. And everybody gets anesthesia unless you absolutely can't.
Okay, thank you. The next question that I have is, what about the injections? Are they painful?
Great questions. The injections are like little droplets of FSH. So it's kind of like a little insulin like needle that goes into your tummy tissue. And again, it is a pinch. It just shouldn't be painful. It's not like a horse needle that goes in your bum or anything. It's just going into a soft tummy tissue. So easier than a blood draw on that aspect.
Okay. And then the last question that I have is, could you add some information on reciprocal IVF? What effects does the age or of both the donor and the age of the carrier have?
Okay, so reciprocal is two women who make embryos, right? And then they transfer each other, their embryo into their partner, right? And so that you're both, one's a bio mom and one's a carrying mom. You both have, um, you know, take part in the baby being born. Um, the age of the woman who is making the embryos affects the egg quality and the percent of embryos that are going to be euploid, right? So I showed that screen where, you know, the karyotype of the embryo is very important, and that's the euploid rate. So the percent of embryos that will be euploid. And then the age of a woman who carries the pregnancy should be in healthy condition. We have a limit of around 50 years old, assuming that she's healthy and she doesn't have any medical contraindications to pregnancy. But the younger the woman is, the fewer risks there are in pregnancy. So being reproductive age is better for the woman who's going to carry.
Okay. Another question that just came through is, how many embryos are usually transferred during IVF? Do you do more than one?
No. So when we transfer one, we have the highest pregnancy rates and highest live birth rates. when you have tested the embryos for the karyotype, the euploid embryo. When you transfer two, it just causes twins, which causes miscarriages. So you have lower live birth rates, higher birth defects, and complications. So one at a time is all that you need. There is still chance for one embryo to split, and that's identical twins, and we can't control that.
Okay. Another question that just came through was, does IVF work for older women or women with low ovarian reserve?
Correct. I mean, older women is all kind of subjective. So yes, we do IVF for women with diminished ovarian reserve of all ages, and we do IVF for older women. I did show that slide where the percent of embryos that you get that are euploid, can be seen. So it depends on your age. When we transfer a euploid embryo, then independent of age, assuming your uterus is normal, pregnancy rates are 50 to 60%.
Another question that just came through is, what are the risks or side effects of IVF treatment?
Great question. I haven't answered that yet. So if you have a high ovarian reserve, you're at risk for hyperstimulation syndrome. We have done amazing things throughout the past few decades in reducing that risk with the medications that we use now. So that's hyperstimulation syndrome, is where your belly fills up with fluid and you're nauseous, and you get kind of sick. So we are really proud of reducing that risk. We haven't had that in a very long time. There's always, when you're doing any surgical procedure, there's always risk for infection, bleeding, damage to surrounding organs. Very rarely there's, risks like ovarian torsion. Which is why we tell women not to do, high impact activities when you're doing your IVF cycle, because when you have lots of follicles in the ovaries, they can twist. It's a 2-week process, so it's short. I always call it fast and furious. And then, a week or two after your retrieval, you get your period. And when you get your period, that's your hormones dropping and all your hormones washing out.
Okay, and then another question that just came through was, what about live pregnancy rates for women between the ages of 39 and 40?
Right. So when we get the euploid embryo, um, you know, if your uterus, I mean, this has to be tailored per person. And I think that really what you want to look at is what are the chance of getting to a euploid embryo. So let's go back to this since we keep getting questions. Okay, so here on average for this age group, we get 14 eggs. And from those 14 eggs, we get 1 to 2 euploid embryos. Okay, when you get a euploid embryo and we transfer that, depending on the quality of the embryo, it's typically around 50 to 60%. So we'll look at all the factors of the embryo and let you know what the chances are, but that's much higher. Remember, pregnancy rates at the age of 40 naturally are only 5% per month. So going from 5% to 50 or 60% is quite high.
Thank you for clarifying that. Okay. Oh, another one that just came through. What are the live birth rates per age group, particularly for higher aged women?
Yeah, so live birth rates are just like about 5 to 10% lower than the pregnancy rates. Again, this is dependent on if your uterine lining and your uterus is normal, right? So if the lining is thin, there's a higher chance of miscarriage. If you have adenomyosis, there's a higher chance of miscarriage, even euploid embryos. So again, live birth rates are going to be 40 to 50%. euploid embryos account for reducing the majority of the risk of miscarriage, but it's not 100%. There's other things like the uterus, metabolic syndrome, which is the higher BMI, high blood pressure, diabetes, so thyroid issues. So there's never a zero risk of miscarriage.
All right, thank you. Okay, I just want to offer the opportunity for anyone to ask any more questions. Okay. Well, thank you all so much for joining us this evening. We hope that you found the presentation informative and helpful as you navigate your fertility journey. I encourage anyone who's joined us tonight to reach out to info@pacificfertility.com to redeem your $99 consultation that includes initial consultation and ultrasound. If you have any follow-up questions, you're also welcome to contact us at 415-834-3095, or you're welcome to just email us at the info@pacificfertility.com. We're here to help, so whatever you need. And on behalf of everyone at Pacific Fertility Center and Dr. Agard, thank you so much again for spending your evening with us, and we wish you all a wonderful evening.
Thank you so much. Bye,
Take
everyone.
care.